all, thank you for the kind introduction. I would like to thank all the professors for your kind invitation. I mean, it's really a pleasure joining your educational course, although I would prefer to be on spot. You know, I have been traveling a lot around your countries. I love them, and I'm going to continue traveling it as soon as it will be. It's already available. So first, sorry. Here I'm back, so it was just that. So I'll first try to share my screen. Okay, I hope everyone sees it.
Yes, we are seeing it.
Yeah, perfect. And just to, yeah. So what I'm going to talk in the next 40 minutes is about the role of nutrition in children with inflammatory bowel disease. And we will talk on the role in the etiopathogenesis, in the treatment with an emphasis on Crohn's disease, but also mentioning the role in UC. I will present you the potential role in the treatment of acute disease and in prevention of relapse. And then we will talk about the role of nutrition in the primary and secondary prevention of IBD. As you are already in gastroenterology, I'm sure you know everything basic about the IBD, the differences between Crohn's disease and ulcerative colitis, that between 7 to 10% we cannot distinguish, and therefore we call it indeterminate. So I'm not going to spend more time about it. Looking at the prevalence, I'm quoting here the famous EpiMAD register in France, because they have been following the prevalence already for 35 years. And as you can see, if we look in general, it is this dotted line here that continues to rise, and it belongs to the age group 10 to 19, so our patients. And if you look more closely into them, you will see that both diseases are continuing to rise. You may say, well, the Crohn's is a little bit diminished, but I wouldn't. It may be just a circumstantial. And the ulcerative colitis, for which we thought that it is stable, it's not stable, it's increasing as well. It's increasing in our country as well. So something is occurring in this age group that we are responsible for, why the disease is increasing. So I can say in general that if you look, what is this beautiful mucosa of the colon and small intestine transferring into this bloody mess of ulcerative colitis and Crohn's disease, we can say in general nicely that it is immune-mediated inflammation, to luminal content or bacterial content in genetically predisposed individuals. Yet, our genetical background has not changed in the last 30 to 40,000 years. So obviously, something is changing in the environment. And since recently, we are talking about the triple environmental hit theory. Basically, it is proposing that the first primary hit is happening in utero, which is making us prone to react to the second and the third environmental hit with developing IBD. In the second period, which is early postnatal period, microbiome, so the gut content, has the primary role. And definitely, food is something that is shaping our microbiome in this period. As for the third, also, we may assume food. However, you might immediately say, okay, what could happen and how can it be transferred through all this period for 10 to 20 years that can make us prone or modulate our microbiome, that after 10 years it reacts and develops IBD? Definitely it is epigenetic mechanisms that can record, remember, and the activity of the genes will change afterwards, enabling development of IBD. So if you look at the environmental factors that may shape us, at least our gut content, it is definitely food. And on this slide, it is summarized how food can shape and what food components could negatively affect our bowel microbial or content. So it is, if you look what can cause dysbiosis or change the metabolome or the possibilities of bacteria to adhere to mucosa more closely or to enter crypts where they shouldn't get an access to or translocate and change the pathogenicity. It is high fat, high sugar, low fiber, emulsifiers, gluten. It is common in almost all 4 these parts of the circle. But food can also influence directly the mucosal immunity. And again, very similar components of food: high fat, gluten, low fiber, low omega-3, alcohol, emulsifiers, are those who may negatively affect. Here you have them on the left-hand side. So diet can shape microbes. They can provide, they are providing a substrate for microbes, and those substrates can be changed into components that will be epigenetically active. One of them is definitely short-chain fatty acids, but diet can directly or by epigenetical means also shape our host mucosal immunity. So we can anticipate that almost for sure, food has an important role in the pathogenesis of IBD. We will need many more studies to know exactly in which way and what type of food. But it is acting either through shaping microbiome and indirectly in this way or directly over the immune mechanisms, both mucosal and adaptive as well. So we can now go on to the treatment and prevention of the disease. And I will discuss that with you on one of our patients. It is not a patient that is made. It is a real child that presented 2 years ago. And he had with the history of, was referred to us with the 3 months of, first with diarrhea, 3 months before, and then the acute diarrhea subsided, and he had occasional semi-liquid stools, periumbilical pain after the meal. I can ask you afterwards at the end why periumbilical pain after the meal, lost 5 kilos, and already at the outpatient, at the actually referring doctor, the infections were excluded, the high inflammatory markers were found, and also fecal calprotectin. And the family history was that the father had a Crohn's disease, and mother and younger brother at that stage were healthy. So this was the reason for referral. As you can see on a physical examination, he's a bit on a lower side, although still not that bad. Perianal region was normal. Again, we checked for the inflammatory markers and for the fecal calprotectin, and all of them were high. And the next step, of course, was the endoscopy. The upper endoscopy was normal. As for the lower endoscopy, the terminal ileum was dreadful. It was stenotic, but it was, as you would see later, mucosal inflammatory stenosis, severely affected with numerous deep ulcerations, cecum ascending, both flexures, and numerous ulcerations after, and in rectum after. And we were lucky to find granuloma in several colonic biopsies, so there was actually, it was not questionable that it's a Crohn's disease, and it was an active luminal L3. So my first question to you, please imagine, how would you start the treatment? So it is a newly diagnosed active luminal disease affecting the colon and affecting the terminal ileum. And here are the possibilities: steroids, exclusive enteral nutrition. You would like to start immediately with anti-TNF, or with aminosalicylates, where my answer would be exclusive enteral nutrition. I might be biased because I've done my gastro studies at the gastroenterology in Birmingham in 1987-88. They used enteral nutrition there. I started using it when I came back home. So I'm using it for more than 35 years. However, it is not just my experience, but for the last 3 consecutive ESPGHAN ECHO guidelines, including the latest update, it is recommended in children with active luminal Crohn's disease. Dietary treatment with exclusive enteral nutrition is recommended as the first-line treatment for induction of remission. So it is a very clear statement, and you may ask me what is standing behind what level 2 of evidence is staying there. Until recently, we were quoting the 2 old meta-analyses, but in the last 3 to 4 years, we have 3 meta-analyses. One of them is Cochrane, including only randomized control studies, and you can see the pediatric studies and adult studies. And in pediatric, they concluded that exclusive enteral nutrition might be compared with steroids. So sorry, in all 3 meta-analyses, exclusive enteral nutrition was compared to steroids. So here it might be more effective compared to steroids. And in adults, the steroids might be more effective compared to exclusive enteral nutrition for achieving remission. Second one, also published in a very good journal, however, including not just randomized, but also the cohort studies. And you can see there is absolutely no difference between corticosteroids and exclusive enteral nutrition. Here it crosses the line of no difference. And the same occurs with the latest meta-analysis, so no difference in efficacy. Why I'm recommending that and why there is such a clear statement in favor of the enteral nutrition. Look here, mucosal healing. This is not anymore crossing the line of no difference, no effect. You have a clear benefit in respect to exclusive enteral nutrition, so it is more efficacious in achieving mucosal healing. And you know that currently we struggle to achieve as the primary goal in treatment mucosal healing. Here I'm citing one of the latest studies in that respect, a French study. It is a prospective, randomized prospective clinical trial. And after 8 weeks of using enteral nutrition versus steroids, looking at mucosal healing also, in clinical remission were all on enteral nutrition, 5 of 6 on corticosteroids, almost similar, but mucosal healing was achieved in 89% on enteral nutrition and just 17% on corticosteroids. So there is a statement in our guidelines, EN promotes mucosal healing and transmural healing in a proportion of patients much better compared to corticosteroids. Next, what we have been looking at were how long the remission lasts after, if it was induced by exclusive enteral nutrition compared to steroids. This is one of our studies. This is the remission length if you used enteral nutrition compared to steroids. The difference is significant. And this is in one of the meta-analyses in favor of exclusive enteral nutrition. Another study, induction with enteral nutrition using early thiopurine versus induction with corticosteroids, similar support to prevent relapse, followed for at least 2 years the respectable number of Crohn's disease patients, and induction with EN was associated compared to steroids with reduced growth failure, less steroid dependency for later treatment, and improved later response to infliximab. Are there any type or location of Crohn's disease, which, for example, EN could be more favored? No, according to this study, no. So the statement in our guidelines are that exclusive enteral nutrition should be recommended in all cases of active luminal disease, irrespective of the location. So my first conclusion is that obviously it is efficacious, it promotes growth and mucosal healing It lacks the side effects inherent to steroids, and for you that would like to use it, just to see how to do it. So is there any particular formula on the market that should be our preference? As you can see, these are the adult studies, but as you can see on this meta-analysis, clearly there is no difference in the type of the formula in respect using hydrolyzed protein or polymeric. Different fat content, different protein content makes no difference. So using the standard polymeric formula, this is they are the cheapest, with a moderate fat content is recommended. There is no reason to use elemental or semi-elemental. How long to use it? You can see here the study showing the different experience in respect to the different continents or countries, Canada, US, UK, Spain, Europe in general. So look here. You can see that they differ in respect to the duration, but most of them use 6, 8, but also 12 weeks. In our recommendation, we said that at least during the 8 weeks, the kids should drink only that and nothing else. Some people allow chewing gum, some allow to flavor it. We allow only this and the clear water. We may discuss it. Why is it efficacious? Is it the bowel rest actually? Is it the improved nutritional status? Is it the direct anti-inflammatory effect? Because you can see that the food components can have a direct pro-inflammatory or anti-inflammatory, or do we change intestinal flora? We have a big project for perspective project. We are following children with the newly diagnosed Crohn's disease and comparing them with their brothers and sisters who are healthy before using enteral nutrition, but also using enteral nutrition, how commonly the flora is altered within the first 2 to 3 days, while their healthy brothers and sisters were willing to drink it as well. The data are yet preliminary, just published the first set of data when we have seen that, yes, immediately flora changes, but even more quickly in healthy siblings compared to the patients. And we are following them now to see how long this change will be after the enteral nutrition has subsided. There is no perfect way. You may ask me, is it so easy? Look here. Do you think it is easy to drink or get this by nasogastric tube? Definitely it is not. And the studies have not shown it. It is true that enteral nutrition inflicts less complication compared to steroids, but it has more adverse effects. It has been shown clearly in the Cochrane systematic review that I presented to you. And it has been seen that induction with exclusive enteral nutrition compared to steroids was associated with significantly increased rate of withdrawal due to adverse effects. And if we looked at what adverse effects, inability to drink all of that, although I must tell you from my experience and compared to the adult data, the children are much better than adults in that respect in being compliant if you are good in introducing it to them, but also other adverse effects, heartburn, flatulence, diarrhea, vomiting occurred more frequently. Do we have a solution for that? Can we use, for example, partial enteral nutrition? And when we talk about partial, at least 50% in the form of enteral nutrition and 50% in a form of normal diet. Already 15 years ago, it was clear no. More recent study comparing the efficacy of partial enteral nutrition to exclusive enteral nutrition to anti-TNFs. And if you look at the moderate to severe Crohn's disease patient, look here, exclusive enteral nutrition was actually the most efficacious compared even to biologics in achieving the clinical remission. But compared to partial enteral nutrition was not efficacious. So the statement in our guidelines is that partial enteral nutrition alone should not be used for induction of the remission. can we modify these 50% of calories that are coming from normal food? I have shown you at the beginning what type of food is actually most difficult and most suspicious in respect to the pro-inflammatory and to changing the flora. So can we avoid it? Comparing with parenteral nutrition, 50% of calories coming from it, and is it efficacious? It has been tested first, but not randomized, in 2 Israeli studies, and this is the only prospective randomized controlled trial during 12 weeks where patients were randomized with mild with moderate Crohn's disease to using so-called Crohn's disease elimination diet, 50% of calories, and 50% of calories coming from enteral nutrition for 6 weeks, and then followed with the second stage of CDED, where it is using just 25% in form of the enteral nutrition. If you ask me what has been excluded, it is not an easy diet, but basically removed wheat, animal fat, dairy, red meat, emulsifiers, carrageenan, and so on. And in another group, it was exclusive enteral nutrition for 6 weeks, followed by free diet and partial and using 25% of calories in the form of the enteral formula. The first outcome was tolerance, and this difference here was not, however, in compliance, in response, in remission, so efficacy was no different, but tolerance was, of course, significantly better in the CDED combined with partial enteral nutrition. But when you looked at 12 weeks, and be aware that for 6 weeks already, children in exclusive enteral nutrition were actually on a completely normal diet, then the efficacy of CDED was significantly better. We have published our data as well, but I must say we call it a modified CDED partial enteral nutrition. It was a retrospective study where we had 41 patients newly diagnosed on exclusive enteral nutrition for 6 weeks, or 1 to 2 only weeks of exclusive enteral nutrition, followed by the partial enteral nutrition and CDED in completely following the same protocol as you have seen already, 20. When we compare them, there was no difference in exclusive enteral nutrition for 6 weeks or 1 to 2 weeks of exclusive enteral nutrition, followed by this CDED with 50% coming from enteral nutrition. And however, the children gained weight significantly better in this modified CDE3. However, this is first a modified version, and the second, there is not enough data, even if we compare the first study and this study. So in the guidelines, there are no current recommendation in respect of using this modified elimination diet compared with partial nutrition. This is another one used in Glasgow, but preliminary data, so I cannot say you a recommendation. Going back to our patient. So look here what occurred with the CRP on the 8 weeks of exclusive enteral nutrition, dropped of CRP on completely normal, yet the fecal calprotectin didn't drop to completely normal. The guy didn't like it and was not very good in drinking it. So the intake was limited, although he was compliant to it. So he didn't gain weight. These 5 kilos that he actually lost, he stayed on the same. And since the end of January, we also introduced Imuran in appropriate dosage. After the 3 months of it, as the calprotectin was, although he was clinically good, but the calprotectin was high, we repeated ileocolonoscopy. You remember the terminal ileum, which was terrible. Now it was just 2 to 3 after, which we found. In the rest of the colon was completely normal, only in rectum circumscript erythema, nothing else. So the activity, there was still some active inflammation. We still found 1 granuloma, but with a significantly lower activity. So my next question to you is, so you have a clinically stable patient, but yet the fecal calprotectin is still high. And here you see much, much better finding, but however, so what would you do? Imuran, at this stage, he was receiving for 6 weeks. Would you change the treatment or wait to see? I was in favor of wait to see, prolong the Imuran to buy some time to see whether Imuran, who needs sometimes around 3 months, even to 4 months to start being active. My next question is there anything that we can do? This child is already, this guy, for more than a month on a normal diet. Is there anything that we can buy time and prevent the relapse and wait for Imuran, or even prevent relapse without any immunomodulatory treatment? And here are the options. Should we simply use, it was efficacious, exclusive enteral nutrition indefinitely? I don't think so. There is no evidence, and you would really torture. It's highly demanding adherence or exclusive, and we will diminish the quality of life. I think you agree, you know, in a way and in a level that we don't want to that. Can we use a partial enteral nutrition? So continue once this is finished with the regular oral intake and 50% of calories or 25% of calories. There are 3 systematic meta-analyses looking whether we can use partial enteral nutrition, providing 50% of calories for maintenance. And the results are, it really may sustain remission. It may prevent, if you use it in postoperative, to prevent postoperative relapse after elective resection. Reduces loss of response to biologics, postpones the requirements for steroids. So the recommendations which we proposed in our guidelines was that in children with low risk for relapse who achieve clinical nutrition with monotherapy with the exclusive enteral nutrition, maintenance within 50% of calories can prolong remission. So continue with enteral? No. Partial enteral? Might. But then you might ask, could we, for example, use partial with Crohn's disease exclusion diet in the way that we have been using it? And it might be for future consideration, but we need to test it and to provide the data. So the conclusion here is that exclusive enteral nutrition is truly useful as the first-line treatment for children with active luminal disease, that if you go for it, use standard polymeric formula for at least 8 weeks. It is the cheapest option. Partial and plus standard diet is not recommended for the active Crohn's disease, but you could use it for prevention of relapse or prolonging the remission. There is also some new evidence on the efficacy of another exclusion diet combined with partial enteral nutrition for treatment of active disease and prevention of relapse, but there is no official recommendation due to the lack of good quality data yet. Going to the ulcerative colitis, we are aware that almost more than 2/3 of ulcerative colitis patients believe that some food component worsen their diarrhea, and they are eliminating foods from their diet very often to the extent which we do not appreciate. But the data are not in favor of using either exclusive or partial for inducing and maintaining remission in ulcerative colitis. Going back to the patient and going back to his family history. His father has a Crohn's disease. Mother and younger brother are healthy. So as the father has a Crohn's disease, as already one, we have a patient. Is his younger brother at increased risk to develop in his future life? Definitely yes. Even if we look that he, just for the father, he has increased risk for 2 to 13 times more for Crohn's than for ulcerative colitis. According to the studies, the higher risk have daughters of mothers with Crohn's disease. So my next question is, in this younger brother, in the mother, can we use a diet to prevent? They are definitely at risk, the younger brother. Can we use a diet to minimize? Remember this triple hit environmental hypothesis. Can we prevent the second hit, for example, in the children, in the future siblings, or the third hit? Is there any diet that can minimize the disease to occur? So we will look first in this early period, second hit period, and the early diet. If we look at the early diet, definitely it's something out of these three, and breastfeeding, I'm sure, would be your option to raise it. Is breastfeeding in the first year may serve as a method that will diminish the risk in siblings that are at risk, for example. All meta-analysis, you can see all in favor of breastfeeding as a preventive method, both for ulcerative colitis and Crohn's. Later studies in the US, being breastfed decreased risk for surgery, for risk of surgery for Crohn's disease. In Asia Pacific study, breastfeeding for more than 12 months decreased, of course not exclusive, decreased risk for Crohn's disease and ulcerative colitis. However, quality of data poor, recall bias there, IBD increasing in Europe in countries with high rate of breastfeeding, and in another study, breastfeeding was actually a risk factor. And if you look at this good Italian study, looking at the epidemiology of environmental risk factors, breastfeeding for more than 3 months was actually a risk factor. And I would draw your attention, look at the other higher risk environmental factors, number of siblings low, not having pets, not sharing bed. Also, early gluten introduction for ulcerative colitis, low adherence to the Mediterranean diet, early introduction of pets, not having pets, and family parasitosis not being there. This is already a later diet and later environment. Looking at the third hit, is there any diet that we can really later prevent the relapse or the third hit in that will push the disease to occur? And when we look at the dietary risk factors as a risk factors that I mentioned at the beginning, remember from my first slides, animal fat, proteins, refined sugar in excess, less fiber, less fruits than vegetables, lower intake of omega-3 L-CPUFA, higher intake of omega-6, addition of emulsifiers, particularly addressed in several of studies. In respect of that, data were summarized in the ESPEN, European Society for Parenteral and Enteral Nutrition Guidelines, published a couple of years ago, and also in our guidelines as well. And the recommendation is that the diet rich in fruit and vegetables, rich in omega-3, low in omega-6 is associated with the decreased risk of developing IBD and is therefore recommended. And we said avoidance of westernized diet might be considered avoidance of food or beverages containing a large amounts of emulsifiers. Look here, sauces, fast food, margarines, ice creams. So dairy might be considered. So before going back to the patient, in ulcerative colitis, the same type of recommended diet. So recommendation on the use of specific dietary restrictions for UC are the same as for CD, should not be used unless potential benefits outweigh of the risks of the diet. When I said should not, a strict elimination diet, not a general healthy diet. So going back, is there any diet that can lower the risk for the currently healthy brother? Most probably yes, and the whole family could have it. Father and a patient to diminish the risk of the relapse, mother and the younger brother to diminish the risk for the new IBD, and it is a healthy diet. We are not talking about the CDED or any strict elimination diet. It is a healthy diet, not an elimination diet. So, dear colleagues, I would like to conclude that definitely diet shapes directly or indirectly over shaping microbiome, the risk for further development of IBD. Exclusive enteral nutrition is efficacious as the first-line treatment for the luminal Crohn's disease, but it has not such a role in ulcerative colitis. There are not enough data currently to recommend any specific elimination diet that would combine partial enteral nutrition with elimination of the certain foods. And specific foods and nutrients can have a distinct role, so avoiding them, but not in a way of a strict elimination diet, could have a role in prevention. And by this, I would like to thank you for your kind attention. And we have still, I think, more than 5 minutes, almost 10 minutes to answer your questions. So please, I will go now to the chat. But I would prefer if you would ask the question in English or to be translated by
I may translate it.
George there or Carlos or Reynaldo.
Yeah, I may translate it. No, don't worry about it. I may translate it.
We can help. Don't worry. Muy bien. ¿Alguno tiene alguna pregunta? Adelante.
Pueden levantar la mano si quieren hablar. Esto es un diálogo, acuérdate, esto no es un webinar, esto es una escuela. O sea, ustedes, you may want to raise your hand and you may ask the question directly to Dr. Golacek. Go ahead. Marina?
Congratulations, Anya. Love the topic. One particular question is, what do you think and what is the main drawback in your center on going into enteral nutrition therapy?
Okay.
Doctors that are not confident, or families that
I cannot say they're not confident. You know, I'm already their boss for 35 years. So they're educated in the way that this is the best way. But anyhow, we do differ. For example, if you ask me, how do I provide exclusive enteral nutrition? I put, when I do the endoscopy, and it is done in the general anesthesia, I put down the nasogastric tube so that there is no, they don't feel offended by or stressed. So they wake up already with the nasogastric tube. And I tell them, look here, because the children hate in my country having a nasogastric tube. So a big constraint is for them to go back home, to go to the school with the nasogastric tube. We are a conservative country, you know. And I put down the nasogastric tube and I say, okay, now you have a week. Try your best to drink these 2 liters or 2.5 liters or whatever, or if you give hypercaloric formula, try to drink it. If you are able to drink it, come back in a couple of days, we will take out the nasogastric tube. I must tell you that 3/4 of my patients after that say, no, we want the tube. I have a colleague of mine, many of you know her because she's excellent, already excellent gastroenterologist, Eva Hojsak. She does it oppositely, not like her boss. She says, try to drink it for a week. If you will be able to drink it, then if you will not be able to drink it, we will put down a nasogastric tube. We have done the study to compare whether there is a difference. There isn't any difference. We didn't find any difference in the weight gain or something like that. So she does it differently. She does not put immediately the nasogastric tube, but she tell them, sometimes they do, there is a taste. I saw that there is the question on the taste. as there is no difference, you know that there is a lot of tastes. So I ask them, try here with those tastes and do like chocolate or vanilla or strawberry, and then what is the best? I must tell you, for example, first they like vanilla or chocolate, then they like strawberry. But you know what is the most favorite taste? No taste. Any taste they hate after a couple of days of using. So if they are not on a tube, and again, I will tell you that 3/4 of my patients after a week trying to drink say no, I go to school with my tube. But if you ask them if they're drinking it, providing a completely tasteless, cold, it needs to be cold, put in a refrigerator, drink by straw so that it goes quickly through the mouth, they preferred no taste, tasteless. Such, for example, like Osmolite. I like Osmolite, it's the cheapest. I like it because it's cheap. Let me see. Is there some group? Please, how many times we could? No, I'm now going over the questions that I can see at the chat box. How many times we could make adapted CD with 2 weeks in a, yeah. This is the single individual experience. So it is a single study in which we have done it our way. In a serious patients, we have used exclusive enteral nutrition for 1 to 2 weeks, and then continued with the 6 weeks CDED, Crohn's disease elimination diet, combined with 50 calories coming. I can tell you only my experience. There is no other studies. So how many times we could make adapted with the 2 weeks and how many weeks for the rest? You give adapted, so we give 1 to 2 weeks of CD. We give them 6 weeks of providing 50% of calories as partial enteral nutrition. Then we give 6 weeks of partial enteral nutrition, providing just 25% of calories. And then you have a modified diet, and they continue on a modified diet. So yes, we have children without any immunomodulators that continue on a modified diet, and they are in a stable remission, but it is too low sample. It is just a couple of patients, and I cannot advise you anything. It is a personal experience. Let me see, and the maltodextrin presence in the formula. Not only maltodextrins, very good question, because if I raise the question of maltodextrin, not only maltodextrin, you have a lot of emulsifiers in the enteral nutrition. So why I'm talking about the inflammatory potential of emulsifiers, and you have a lot of them at enteral nutrition. Excellent question. Yet it works, it really works. So I don't know why. Perhaps the benefits outweighs the potential addition of the emulsifier. I have no explanation. Then there is a question, what would be the explanation for exclusively having an increased risk? I wouldn't say an increased risk. I would say that there is innocent, that breastfeeding here is innocent bystander. You know why? Who is breastfeeding longest in Europe? In the most developed countries, such as Norway, sorry. So you have Norway. They definitely have all these influences of emulsifiers and the low number of siblings and not having pets and not sharing the bed with siblings, you know, but breastfeeding. So I would say breastfeeding is not guilty. I would say prolonged breastfeeding here is an innocent bystander. Other patients with colonic, look here. When we have a perianal fistula, particularly if we have severe perianal disease, you know that according to the latest guidelines, they are eligible actually for the induction with biologic treatment. Severe, perianal disease. But if you ask me about the simple perianal fistula, for decades, we have been treating them with enteral nutrition and with metronidazole, and we definitely could get rid of them in a significant number of patients. But we always added antibiotics as well. Are there any other...
Dr. Kolochev, thank you for moderating your session. There's an intervention. There's an intervention from Vera Zipanian, who is in Sao Paulo, Brazil. Vera.
Hello, thank you. Congratulations. It was a beautiful class that you gave us. Please, I'd like to know, we did a study about to quantify the calories per day for each of these children or this child that will receive exclusive enteral nutrition. For example, we generally do the Harris and Benedict adapted. That is, we think there is a little bit higher calorie when we compare with Schofield, for example, formula or DRI. I would like you to say, people say, 150 calories per kilo, but it's not this. And I think it's important to think about the calories that we have to give for each day, because he will gain weight according to this. If we will restrict this diet, he will gain low weight.
Yeah, I fully agree with you, Vera. It's an excellent suggestion. We don't do it in such a way. We really don't do it so proficiently as you do, so you're a step ahead of us. But what we do actually is, to calculate what would be the ideal weight for the child who is presenting, because we are talking a diagnosis, for example. So what would be the ideal weight? And we calculate the calorie for the ideal weight. So we add a bit, but you have to be aware that we increase stepwise. So we don't start with 2,500 calories immediately, but through several days. The problem is that they limit the intake because they hated the taste. That is the problem. They cannot take 2.5 liters or 2 liters, but your way you are doing it to make a proper calculation for the calories required, but then you need also nasogastric tube to push all that calories in them. But I must tell you that the children in our hands really are compliant, are compliant.
In our hands also, and I think it depends the way that you convince them.
Last question is about what do you think about the combination of EN and anti-TNF therapy?
Honestly, I don't see why to give the purpose to give it together. Because you give exclusive enteral nutrition to avoid biologic treatment, to avoid it, to postpone it. That kids will live for the rest of their life with Crohn's disease. You want to postpone it in a nice way, not to make them more at risk on a long term, but to postpone the introduction. I would think about perhaps introducing exclusive enteral. You have those who are non-responders and they are on a biologic treatment. So I would add, you have non-responders, the child comes in a relapse under the biologic treatment. You have already used adalimumab, twice higher doses, twice shorter period. Your hands are tied. Then this might be the situation where you really have a sick child, and here you either have to provide corticosteroids or this is an option to introduce exclusive enteral nutrition. So I wouldn't do it routinely, but I might use it in a special circumstances where the child already is at biologics and they don't work, and it happens, you know, it occurs commonly.
Very good, very good. Carlos, no sé cómo estamos el tiempo.
Podemos un par de minutos más, si quieres, no hay problema.
Okay, so since we have a couple of minutes, there's another question about, okay, studies regarding EN in very early onset IBD, monogenic and non-monogenic form. Do you have some experience?
I haven't seen the study, I must say. Perhaps one of you have seen the study. We have used it, but we used actually the elemental form in that case. So I was talking about no difference between polymeric elemental, but in these two kids, we used the elemental form. They presented already as infants, and in one it helped, but I must tell you that one was not that seriously sick, and the very early onset IBD are usually very sick. So they are too sick, and it's not helpful usually, I'm sorry to say.
Okay, and the last question, which is a question that is also always posed in discussions of the, do you think there's a role for probiotics in the management of IBD?
I am not, no, not me. It is not my opinion. There have been a lot of studies, good studies summarizing it in Crohn's disease. No, neither for introducing remission, nor to preventing a relapse. In ulcerative colitis, some, yes, for some probiotics, such as E. coli Nisl. So it is a probiotic dependent. You cannot just say yes, probiotics. It is probiotic dependent in some circumstances. For example, preventing pouchitis or treating pouchitis after the colectomy. So in Crohn's, no. In ulcerative colitis, in some cases.
Very good. Juan, ¿estás por allí? Juan, Silvia, creo que podemos despedir a la doctora Koleshev.
Thank you, Dr. Koleshev, and we are glad to have you here.
Thank you very much, Sandhya, for participating once again. I think this is your second time with us, right?
No, first time.
This is your first time, right?
Yes, I hope it is not the last, and I hope I will come on site.
You're right, you're right. Last time in Puebla, I don't remember who was with us from Espegan, but thank you and welcome, always welcome, okay?
Bye-bye, thank you.
Bye.